This meeting is called to order. If everyone will rise with me for the Pledge of Allegiance, please. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, would you take a roll call, please?
Director Danielson.
Present.
Director Nicholson.
Present.
Director Stewart. Present. Director Wallace.
Present.
Director Epen.
Present.
It comes that time of the year where we are changing officers. So we have, next on the agenda is election of officers. Would one of the board members care to make a motion?
Madam President, I'd like to make a motion on that item. I would propose that the new president for the coming year be Michael Wallace. The first vice president be William Nicholson. The second vice president be Bernard Stewart. Treasurer Jacob Epen, with Pat Danielson as secretary.
Is there a second?
Second.
All in favor?
Aye.
Aye.
I have done my last duty as president. Thank you. Mike, you may have my chair. You may not have my pillow.
You're going to help them move the name tags, Catherine?
Oh.
Give me my pillow. There you go. Congratulations.
Oh.
Take your cookie.
Take my cookie.
Yeah, I get my pillow, you get your cookie.
You want your water?
No, I didn't touch that. I got
Well,
one.
okay.
Didn't think of that one.
Okay, good evening, everyone. Thank you, Pat.
You're welcome.
Okay, we are going to move into the education session. So Nancy, please.
Tonight, we're going to hear from Dr. Vandana Sharma. She received her medical degree and PhD from the University of Chicago, Pritzker School of Medicine, and completed internal medicine residency and an oncology fellowship at Stanford University. She's board certified in oncology and in internal medicine. She's done extensive research in oncology and has published papers relating to breast cancer and cancer genetics. She was this year's recipient of the Empowerment Award from the HERS Foundation and is our medical director for the Washington Hospital Cancer Genetics Clinic and our oncology program. And with that, I'd like to turn the program over to Dr. Sharma.
Sure.
Thank you. It's my pleasure to come and speak here before the board. I'm going to talk a little bit today about our new infusion center, the Washington Hospital Sandy Amos RN Outpatient Infusion Center. So as I was preparing these slides, I was looking and seeing that I had actually spoken in front of the board back in 2007 when I gave a presentation about cancer and the need and the desire within the medical staff and the hospital administration to really develop a solid oncology program. We had a lot of the pieces and we just really wanted to bring it all together. And I think tonight you'll see the culmination of a lot of that effort in trying to get some of the services more integrated and under one umbrella. So here's a view of the infusion center. You can actually see it in person just up on the second floor here in the 2500 building. There's a very lovely and warm and welcoming entrance that leads into a really nice waiting room. And why is this such a big issue, and why is this something that should be a focus of our hospital? And that's basically because cancer is the second leading cause of death in the US, second to heart disease. And I think it's appropriate that the infusion center is actually opposite to cardiac rehab. So upstairs on the second floor, cardiac rehab is on one side and the infusion center is on the other side. And I think it really shows how we're committed to really making a difference in the number one and number two leading cause of morbidity and mortality for patients in the US. The American Cancer Society predicts that there will be 1.5 million new cases of cancer diagnosed each year. And of those cases, approximately 500,000 people will die from their disease. About 44% of men and 38% of women will actually receive a cancer diagnosis in their lifetime. It's a disease of aging, so as we age, as our population ages, we're going to see more and more people getting diagnosed with cancer. The good side of this is that we're actually making a lot of progress in terms of our treatment of cancer and improving overall survival for individuals. So now there are actually 11.7 million cancer survivors in the US, and that comes down to 1 in 20 adults. The cancer is a reportable disease, so every year the American Cancer Society publishes data on cancer incidence, sites of cancer, as well as death rates. And for men and women, the number one sites are still breast for women and prostate for men. However, the leading cause of death are still cancers of the lung in both genders. But you can see, even though there's been this increase in the incidence of cancer, there's actually been somewhat of a downward trend in terms of mortality. So we've actually made a lot of progress in terms of cancer treatment and helping our patients live with cancer. And for some people, cancer is actually becoming a chronic disease. They're not dying from their cancer, but they may be actually dying from heart disease or stroke. So you might ask, why an infusion center? Why is this an important part of our cancer program? And basically, it's because cancer patients have a unique set of needs. They have a unique set of medical problems, psychosocial issues that they face at the time of their diagnosis, throughout the course of their treatment, and then perhaps into their survivorship years, and then if their disease relapses and is not curable, in terms of palliative care, comfort care, and hospice. The majority of oncology care actually happens in an outpatient setting. So many doctors don't even have the opportunity during their training to really see what it means to be an oncologist, because most doctors in training encounter cancer in the inpatient setting. That's usually when the patients are acutely ill. But the majority of cancer, 90% of cancer treatment, actually happens in an outpatient setting, and that outpatient setting centers around an infusion center. Improved survival actually means more years of therapy. So individuals are now staying on chemotherapy for up to 3, 4, 5 years, as opposed to just 6 months. So that setting in which they receive that treatment really has to be holistic, it has to be comfortable, it has to be suited for their needs. The individuals who are providing that care have to also be trained in the special needs of oncology patients. And that's very important in terms of the complex clinical situations that they might face in terms of symptom management, as well as any kind of acute infusion reactions or allergic reactions to the medications. Finally, as I said, there's an increasing number of cancer survivors, so there's a need for a centralized place for where survivors can have information, get access to support groups, get access to other sorts of rehab services that they might need. So here's an actual view of the infusion center. This is not a magazine picture. This is actually what the center looks like upstairs. It's lovely. It looks out onto the atrium, and you can see here's the infusion chair. It's a fully automated chair, so the individual patients who may have some joint pain or other discomfort can relax their head, lift up their feet, and really have their treatment in a comfortable setting. There's a chair for a family member or a caregiver to sit in, which is actually also very comfortable. One of my patients was one of the first people treated here this week, and her patient sat here, felt like she was at the spa. Her granddaughter sat here and knitted a sweater, and I think it was quite a lovely experience for both of them. There's an individualized media entertainment center. The infusions can be quite lengthy, and while patients are sitting here, perhaps for the 4 or 5 hours, they can watch a movie, they can listen to music, they can really enjoy their interactions. There's also screens that come forward and move back for privacy on both sides, and then obviously a curtain. So this is the direct view out, looking out into the atrium, cardiac rehab, like I said, on the other side, and it's just very lovely. There's also window shades that can be brought down if people want extra privacy. There is a single bed in case there's an individual who needs to be recumbent while receiving their treatment or needs some sort of more isolation or privacy. Procedures can also be performed in this room as well. Simple procedures that don't require excessive monitoring. This picture actually demonstrates one of the important features of an infusion center is the ability for patients to interact with their neighbors. Cancer patients often get a lot of support and advice from people getting treated in the chair next to them. And this system, as you can see, where the chairs are next to each other, allows for privacy when needed by closing the screens, and by opening the screens, two patients can sit and talk to each other and have some social interaction and support during their cancer treatment. These are two of our cancer navigators. We have 3 navigators who've gone through extensive training in terms of cancer navigation. And this really speaks to the fact that the nurses and the staff who are going to be working in the infusion center are not simply nurses who are there to just hang chemotherapy. They're really there to take care of the whole patient, to provide the kind of support and quality cancer care that individuals need throughout the course of their cancer treatment. They're navigators, they're not only nurses, but they are nurses, they're oncology certified and oncology trained. So a summary of some of our comprehensive cancer services. So our program has been accredited by the American College of Surgeons, a national accreditation program for breast programs. We actually received the American College of Surgeons Outstanding Achievement Award, which is only given to the top 15% of programs nationwide. We will be up for our accreditation next year, and we fully expect to receive another 3-year accreditation, and we're aiming to receive the Outstanding Achievement Award again. We're also accredited by the American College of Radiology for stereotactic biopsy. The comprehensive cancer services that we have available include a multidisciplinary cancer care team, which includes the work of diagnostic and therapeutic radiology, radiation oncology, surgical oncology, and medical oncology. And I realize and I apologize for leaving out the pathologists who are actually integral to this process, and I'll have to add that. We have regular tumor boards in general oncology, breast oncology, and neuro-oncology. These provide opportunities for multidisciplinary discussion of cases as well as education. With regards to the patient, there's the patient navigation. We have the breast patient navigator and the general oncology navigators, as well as patient support services, many of which are housed in this facility. But by having the infusion center here on site, they will allow for integration and allow the patients to have ready access to all of these services, which include nutrition, lymphedema, patient library, bras for body and soul, support groups, Reach to Recovery, which is a volunteer program that can help link up individuals with other patients who have gone through similar experiences, as well as the future, which is going to also include palliative care and hospice, which is very integral to our field. So what this means is really a cycle where we have, for the patient who's at the center of our focus, a full service of treatment and symptom management and disease management, going from diagnosis, treatment, survivorship, as well as end of life. Thank you.
Thank you. Any questions, John?
Dr. Sherman, I just want to point out that in addition to pathologists, you have not only 1, but 2 plastic surgeons that come to breast tumor board on a regular basis.
Okay, I'm going to edit my slides just right now.
Okay.
Any questions from anyone?
And we welcome their contribution to all aspects of our patients' care.
Well, okay. Well, thank you, Dr. Sharma. Thank you very much. We're going to move on to consider the minutes of the November 9th, 21st, 28th, and December 2nd meetings.
So moved.
Yep.
Second.
Okay, any comments? Okay, all those in favor?
Aye.
Opposed? Motion passes. Okay, at this time, we're going to open up for communications. We have, okay, thank you. Okay, so Annabelle Torrio. Annabelle, we have a full agenda, so we're limiting the conversations to or your comments to 3 minutes. So please feel free to start whenever you feel.
Good evening. My name is Annabelle Torrio. I'm a union steward for the EBS department and a representative for our union bargaining team for UHW. About 2 years ago, I was standing in the same spot asking for your help. for a fair negotiation for our contract. Back in June of 2011, we all met with management and agree that we don't want a repeat of what happened back in 2009. But so far, it's December, the year is almost over, and we might be heading in that direction. Let's negotiate fairly to provide Washington Hospital's employee and their family a decent cost of living adjustment and avoid the headache and drama. Because we all know everyone are hurting in this economy. The hospital should take care of their employee and their family. The union will do our share as well. Thank you.
Thank you, Annabelle. Okay, any other oral communications? Okay, Dr. Romano?
Mr. Wallace. The credentials report for this evening is the following. Medical staff is recommending the appointment of Dr. Suitha Kausik to the Provisional Active Staff in Pediatrics, to Vinod Kurupath to the Provisional Active Staff in Gastroenterology, and Amy Tun to the Provisional Active Staff in Pediatrics. We are recommending the reappointments of Drs. Basil Besh to Orthopedics in the active staff, Robert Black, Ophthalmology and the ambulatory staff, Albert Brooks, OBGYN to the administrative staff, Mundeep Chawla, Medicine to the active staff, Gail Dressler, Family Medicine to the active staff, Joanne Falkenberg, Family Medicine to the active staff, Richard Frieder, OBGYN to the active staff, Afshin Gayumi, Family Medicine to the active staff, James Hartford, Orthopedist to the active staff, Mark Karansky in Department of Surgery to the active staff, David Levin, Pathology to the active staff, Surjit Mahal, Family Medicine to the active staff, Danny McCarthy, Teleradiologist to the courtesy staff, Rashmi Patel, Internal Medicine to the active staff, Huey Fan, Pediatrician to the active staff, and Mark Saleh, Urologist to the active staff. The following physicians are for non-reappointment, i.e. deemed to have resigned. These 5 physicians are all teleradiologists who are part of a group that are no longer contracted with the hospital. Susan Dingus, Britta Gooding, Junhong Min, Peter Roos, and Thomas Vreeland. There are 2 physicians for whom we are recommending transfer in staff category. That is, they are James Hartford, orthopedist from active to courtesy, and Dr. Harry Puri, former chief of staff and longtime physician on our staff, who is coming off his leave of absence, retiring and going to the honorary staff. Dr. Gunjan Saxena, we are recommending to discontinue the proctorship of initial core privileges and to advance their staff status from the provisional to the active staff. 2 physicians, we are recommending extension of proctorship and staff status advancement for 6 months. That is Dr. Khan and Dr. Stanton, both cardiothoracic surgeons. We are recommending extension of proctorship and staff status advancement for 4 months through April of 2012 for Dr. Thomas Steckel, an OBGYN hospitalist. This is regarding his initial proctorship. Kate Wong, a physician assistant. We are recommending additional privilege in chest tube removal. And finally, we have 1 resignation, Dr. Patricia Barnes, a teleradiologist, who is changing her practice.
Thank you. Okay, can I have a motion for the approval of the credentialing action items?
Mr. President, I move for approval of the credentialing action items.
Thank you.
Second.
Thank you. We have a second. Any questions or comments? All right, so then all those in favor? Aye.
Aye.
Opposed? Motion passes. Okay, we are now going to move to the Service League report.
Catherine.
Catherine is going to give the report. I was looking around the room for another speaker, but
Catherine.
go ahead.
Good evening. Before I talk about the Service League, I would like to tell you.
You gotta tell them whose
I'm
notes
sorry.
these are.
Oh, I'm sorry. This is Andy Estevez, his report, and he wasn't able to be with us this evening. So
Okay.
I'll read it on his behalf. Good evening. Before I talk about the Service League, I would like to tell you how I felt at the Central Utility Plant grand opening. As I listened to Nancy Farber talk about the new building, I felt the pride in her voice for all the accomplishments of the hospital board, everyone involved in the construction of the plant, and Ed Fahan for seeing the project from beginning to end. Over the past 2 years, every time Ed gave the update on the building project, I could see the project was his passion, and he talked from the bottom of his heart. I was very proud to have the chance to be there at the grand opening. I would like to thank Cherie Gamardo and the 42 Service League volunteers who volunteered 375 hours in 3 days, working from 7 a.m. to 7 p.m. in order to help sell almost $100,000 worth of $5 jewelry. Jeannie Yee and Gail Tomita did a magnificent job. I mean magnificent. Jeannie and Gail handled all the money, and as a matter of fact, I had to push Jeannie and Gail to get them to take a break because they are so dedicated to their volunteering. Gail not only volunteers for the $5 jewelry sale, you can find Gail making puppets and hankies, staffing the main hospital lobby desk, and constantly checking so the emergency room does not run out of the stickers and puppets for the children. As far as Jeannie is concerned, there is not one volunteer in the Service League that does any job like Jeannie does. Most of the work that Cherie does for the $5 jewelry sale is countless hours behind the scenes, notifying the community of the event. Thank you to all the hospital staff for supporting the jewelry sale. And when I say supporting, the employees bought $35,000 worth of jewelry. Since September 2007, the Service League made $106,216 in profit from the jewelry sale. From July 1, 2010 to today, Service League volunteers staffed 94 different community events for the hospital. From classes about diabetes to the concert in the park, 296 volunteers gave 878 hours of service in support of our community. Fran Stone, my future trainer, Joyce Wallace and Linda Orr are my special ladies in the gift shop, and I want to apologize that I give them such a bad time every time I see them. They take care of the hospital gift shop like it is their own special gift shop. Over the last 12 months, these 3 women volunteered 1,640 hours in the gift shop. That gift shop looks beautiful. At Christmas time, they decorate the gift shop like they decorate their own homes. I stand there on the side and watch them putting one gift here, and they discuss it and don't like it here or there, and they move it again and again until they find the right place for everything. There is still time for you to check out the gift shop for your holiday shopping. Finally, I'd like to take a moment to wish all of you a Merry Christmas and a happy, healthy New Year.
Okay, well, thank you, Catherine. All right, now, Dr. Romano.
Thank you. I
back
have
to you.
the medical staff report. We currently have 526 members on the medical staff, 398 of whom are either active or provisional active, and an additional 22 members of the Allied Health division that we oversee. There are 15 pre-applications in different stages of processing from various specialties. We have 13 applications being processed, 12 of whom are physicians, 1 perfusionist, and the top 3 on that list are those who you approved tonight. There are an additional 3 applications tentatively scheduled for the next meeting in January. There is a clerical error in the form. It's for Dr. Jeffrey Thomas. It says he's cardiothoracic surgery, but in fact he's neurosurgery. And then we have 4 sets of temporary privileges out, one in fact to Dr. Thomas, who is not only a neurosurgeon but a neurointerventionalist, meaning he can do it percutaneously, and then if it needs to, it can go to the operating room. He could take it directly without requiring a second physician. And the other 3 are the physicians who you approved tonight. And that's my report.
Thank you, Dr. Ms. Farber?
And I'd like to start this evening with Ed Vane giving the construction update.
Thank you, Nancy. So as was noted, we had a open house last week, and I think you could see a lot of the central plant either completed or very nearly completed. So we won't have a lot of time going over the improvements there. I think you've seen them all. All the equipment is in. This past weekend, we finished tying over all the emergency generators, so the hospital is now on the emergency generators from the main plant. Coming weeks, we'll be turning over the boilers and getting the boilers operational. So we'll just continue to do commissioning and have I think our date is around January 10th to have that completed and have everything on the central plant. I have a few pictures of the office space that's up on the top second floor, and furniture has been moved in there. This is workbenches for the different engineers, and there is a conference room as well. Let me move on to the Center for Joint Replacement. Work continues out in the patio that is the exercise garden. This is the conference room on the basement level, so cabinetry is beginning to go in there. Flooring going in the hallways on the first floor, patient care area. This is painting being done in the doctor's office side of the second floor. This is painting on the patient care services side of the second floor. And you can this is again patient care rooms, second floor, and you can see that we're moving along there in terms of the construction. This is the exterior exercise garden floor or ground level walkway around the exterior of the building. And we still are working towards final completion on everything for an mid-April date, and a move-in then shortly thereafter. We're continuing to do fine in terms of budget, and we're still functioning well within our budgets. Okay. Any questions?
Questions? Comments? Thank you, Ed.
Thanks.
Next, I'd like to have Jan Wood come up and talk about the International Magnet Conference that our staff attended.
Thank you, Nancy. I just want to do a quick rundown of our journey to get to where we are, and then share with you some pictures of a really exciting conference that we attended. Remember, 2010, we spent the year getting together our data, writing our document, taking pictures, and doing education. And in February of 2010, we submitted our document. We were the first hospital in the United States to submit our document online. And in May, we were notified that our document was accepted with no corrections and no additions, which is, again, unusual. And I think part of it was because we did submit online. Then in July, we had our magnet visit. And they came for 3 days, and there were 5 of them, and it was tougher than Joint Commission for a lot of us. On September 19th, they notified us that we had been accepted and received our magnet notification. And then in October, 13 staff nurses and myself and Alice Santos went to Baltimore for 3 days for the actual magnet conference. There were 6,500 nurses from all over the United States. It was pretty overwhelming, but it also was very, very exciting. So I just have a few pictures to share with you. This is the sign that was made and was put up. This is the group, and you probably know some of them. This sign was put up and made for us actually by staff here so that we could take it and could be recognized. This is the group. You probably know some of the nurses, Alice, Martha Gilbo. And it was unusual because most of the people there were management. And when we go to these events, we take our staff. And so we're always seen as a little different. This was a sign that we put up in our section. And so when our name was called and they acknowledged us, we all jumped and hollered and threw all sorts of stuff. And this is our group again. It was a very exciting time for everybody. And that was the end of what we did. Thank you.
It would seem a very appropriate time now to interrupt the board calendar section and ask Scott Haggerty to come forward. our Supervisor Haggerty is here to make a special presentation.
Well, good evening. And it's great to be here. And I, first off, need to say I apologize for being late. This is the first time in 15 years that I have shown up late to give accommodation. And I apologize. I left Oakland an hour and a half ago. And I will say this too, because I think it's important. It should be duly noted that I violated carpool laws just to get here. So I did look in my rearview mirror a lot, but I do apologize to you because I think this is a great day for Washington Hospital. And I was reflecting earlier about coming down and speaking to this board and thinking about Washington Hospital and all the great things that this hospital means to me as somebody who lived in this community since 1958. I've spent many nights here for myself, for my kids, for my family. I've had great tragedy here. I've had great sorrow here, but I've also had some good news here. And most of the time it's been good news because of the great staff and the leadership of this hospital. So I did, when Nancy Farber first sent the message out alerting me that you had received this magnet status designation, I immediately told my staff that you need to put together accommodation. The purpose of that was, in county, we don't get to hear a lot of great things about hospitals unless it seems like it's coming from this end of the county. And so whenever there's discussions about hospitals at the county, I usually get to sit back and smile because not all hospitals are in the shape that this hospital is in. And I think it's a testament to Nancy Farber, her staff, and also to the board of directors that makes the decisions here. So I did want to come down and, Mr. President, I don't know if you want me to read this.
Sure.
I will read it. Now this is a test to see, after driving an hour and a half from Oakland, if I'm not too frustrated to be able to read. But I will do this because it is important. And it says that this is accommodation from the Board of Supervisors, County of Alameda, State of California, Washington Hospital Healthcare System, receipt of magnet status designation. And it says, whereas Washington Hospital, local provider of healthcare for the Tri-City area and one of the region's best medical facilities, has been granted magnet status recognition by the American Nurses Accrediting Center, and whereas the magnet recognition program recognizes healthcare organizations that provide nursing excellence, and evidence shows that magnet hospitals have better outcomes with fewer complications, lower mortality rates, and more satisfied patients and more satisfied nurses. And whereas the designation by magnet recognition means that the hospital provides a superior level of health care for patients, displays innovative practices, and employs nurses as part of the team who perform excellent work. And whereas in 1994, under Nancy Farber's leadership, Washington Hospital made a strategic decision to invest in its nurses as critical element to its overall success and delivery of health care to the residents of Fremont and Alameda County. And whereas Washington Hospital is dedicated to attracting and nurturing staff of highly trained and experienced nurses who are passionate about working together to achieve the best possible outcomes for its patients and transforming the culture of its nursing staff to the focus of exemplary professional practice. And whereas in addition to its many accomplishments, Washington Hospital has also been recognized for demonstrating 7 exemplary practice areas ranging from a patient-first ethic to a focus on staff education and training. Washington's commitment to education and the advanced degree that a large percentage of the nurses staff is a reflection of a highly quality care that patients receive. And whereas the magnet... Can I take a break here for a minute? Y'all have done a lot here. And whereas the magnet designation is the highest level of recognition that a hospital can achieve for nursing excellence and helps attract the highest quality talent in the medical field. And whereas Washington Hospital implemented a high nurse to patient ratio before it was mandated by the state of California, and today's honor of receiving the magnet designation is a direct product of the investment and the great testament to its nurses, its management team, and its board of directors. Whereas Washington Hospital is only the 5th hospital in the Bay Area and 24th in California to achieve this recognition, and only 6.7% of the hospitals in the United States have earned this status. Now therefore be it resolved by the Board of Supervisors, County of Alameda, State of California, does hereby recognize and commend Washington Hospital Healthcare System and its nurses, its management team, and its board of directors for their outstanding accomplishment and significant contributions to the citizens of Fremont and Alameda County. Be it further resolved that Supervisor Scott Haggerty, representing Fremont, congratulates Nancy Farber, CEO of Washington Hospital, and extends best wishes for continued success for many years to come. Mr. President, I'd like to give this to you.
Thank you. Thank you very much.
I just wanted to say briefly that I think it's really fitting that, Scott, you were the person that was delivering this to us, because you have truly been a friend of the hospital, and we really appreciate your ongoing support and care and love for this place. So thank you very much. Thank you. Thank you.
Thank you. That's lovely. Thank you. Want to go back to the rest of the calendar? It's not as exciting as that, but it's still good stuff. On November 17th and on December 5th, 6th, and 8th, we did community outreach. The subject was hand washing. And we were at Grimmer and Wybell Elementary Schools in Fremont, Vallejo Mills Elementary School, also in Fremont, and James Lech Elementary School in Fremont. And we had 281 kids go through the hand washing class. This is an important thing to be emphasizing as we're entering into the flu season. This hopefully will help in prevention of infections and the spread of germs. On November 17th, we participated in a statewide medical and health disaster drill exercise. This is something that happens annually. It's a comprehensive exercise that involves hospitals, clinics, and the public health departments across the state of California. The exercise involved a simulated contamination of the water supply, resulting in a surge of sick people presenting in the emergency room, and the activation of the hospital's emergency response plan and the hospital's command center. Our participation in the exercise met all federal, state, and Joint Commission requirements for disaster exercises, and lessons learned as a result of the exercise will be incorporated into the hospital's emergency operations plan. On November 17th, we had a program called the Holiday Dessert Makeover. It was held in the Women's Center. Anna Mazzei, our certified diabetes educator, presented this program on how to make desserts more healthy. On November 19th, we held our diabetes health fair. We had 169 people in attendance, 113 blood pressures, and 103 cholesterol and glucose screenings were provided. Paulette Grilly, RN, Manager of Health Promotion, spoke on positivity, a positive approach to managing diabetes. Anna Mazzei, our certified diabetes educator, and Alfreda Macias, our chef, presented a cooking demonstration. This annual program was designed to educate the community about diabetes, including treatment and prevention. The health fair, as I mentioned before, did include blood glucose, cholesterol, and blood pressure screenings, along with the opportunity to speak with Dr. Prasad Kata, who's an endocrinologist, Dr. Jorge Alanis, who's a podiatrist. On November 28th, our Speakers Bureau presented a program on nutrition and Parkinson's disease. We had 30 people attend. Kim Alvari was faculty for that presentation. On November 28th, 30th, and December 5th, we had our Trees of Angels for hospice, beginning with McDonald's on Mission Boulevard and 680 in Fremont, followed by the one that was held in Nakamura Clinic in Union City, and the final one at the Newark City Hall. The tree lighting ceremonies were held in support of hospice care in the Washington Township district area. over 600 people attended. We gave a program on December 1st on Diabetes Matters, Diabetes and Overview. Dr. Archana Bindra, who's a new endocrinologist in our community, and Sandra Mertsdorf presented this program. We had 27 people in attendance. On December 3rd, we had our community outreach in the tattoo removal program. And once again, Dr. Barbara Kostick was there to do this project for us. 22 patients had their tattoos removed. On December 3rd, we also did the 16th annual Children's Holiday Breakfast featuring Ronald McDonald, Santa Claus, and Mrs. Santa Claus. 200 people were in attendance. This event featured a magic show by Ronald McDonald, photos with Santa Claus, and a breakfast provided by the Bernardin family, McDonald's. On December 6th, we had a program on wound care and the latest treatment options, and this was presented by Dr. Prasad Kilaru, the medical director of our Wound Care Services program and Washington Hand program. He discussed treatment options, including hyperbaric treatment for enhancing wound care and healing. Also on December 6th, this was a big day, we had a stroke program on the acute management of stroke and chronic care and stroke rehabilitation. Our faculty were Dr. Ash Jane and Doug Van Houten, RN. On December 7th, we did community education. The subject was vaccine update for adults, the facts about influenza, pneumonia, and pertussis vaccines. Dr. Javid Siddiqui, who has a master's in public health, presented this program. He's the past associate professor of infectious diseases at UC Davis, and he was invited to speak here by Dr. Diane Martin. On December 8th, we had a community program, which has already been discussed this evening, and it was the power plant open house. We had 220 people attend the ribbon cutting. This is the first of the buildings to be funded in part by Measure FF, the $190 million bond issue measure that was approved by the voters in 2004. On December 12th, we had our management staff holiday donations. Rather than give each other gifts, we decided that we would like to partner with One Child and the Fremont Health Start to provide holiday gifts for students from Grimmer Elementary School and the School for the Deaf, both located in Fremont. And the children were selected through One Child, and we had a total of 87 children have their holiday wishes granted as a result of the management staff donations. When all was said and done, there were 12 bicycles in the room. It was pretty impressive. On December 13th, we met with all of our unions to discuss a number of items. Chief amongst them was a resolution drafted and presented by SEIU. The union rep, Aksan Mulaman, I'm going to make a mess out of your name. I apologize, Aksan. That was presented at our last board meeting. This resolution petitions all employees and management to work together in an effort to mitigate the cuts to Medicare and the Medicaid programs. After that meeting, first meeting on November 11th, all of the unions with whom we have a relationship at the hospital agreed to formally state they fully support the resolution that SEIU had drafted on this subject. I have copies of the resolution tonight. Would you hand them out to the board members? And I would ask the board members to consider this for action in January at the next public meeting. On December 14th, we had tours of the new central utility plant, and district residents were invited to tour the plant, talk to staff, and learn about the vital functions the facility is going to support. There were 3 tours offered, and each took about 30 minutes. In terms of upcoming health promotions and community outreach events, on January 5th, we're going to have a program on diabetes, and it will address dietary supplements and what people should know. It will start at 7 p.m. and end at 8. And Lori Roffelson, a registered dietitian and certified diabetic educator here at the hospital, will present the program. On January 10th, the Women's Center will have a Lunch and Learn program, and the subject will be cancer in the family and am I at risk? And that will be from noon until 1 p.m. And Dr. Vandana Sharma, who you saw earlier this evening, will give the program, along with Nikki Chun, who's a certified genetic counselor. In terms of activities in the foundation, we already heard about the 3 Tree of Angel events that were held over the last 2 weeks. For the last 16 years, the Tree of Angels has raised funds and awareness of hospice care throughout our community. This year, the funds will support the new hospice program at Washington Hospital. At the event that was held at the Bernardin Family McDonald's at 680 and Mission, the Prince of Peace handbell ringers entertained the crowd, and Mayor Bob Wasserman lit the beautiful angel tree. 2 nights later, Vice President of the Foundation, Carol Dutra-Vernacci, lit the tree at the Nakamura Clinic in Union City. And on December 3rd, the Children's Holiday Breakfast took place with over 200 guests and volunteers filling the Anderson auditoriums. Ronald McDonald and Santa and Mrs. Claus entertained the young guests. The campaign wrapped up on December 5th with the lighting of the trees outside of Newark City Hall. I would like to thank Mark Bernardin and Lonnie Robinson of RK Electric and all the Trees of Angel sponsors for their support during this holiday season. During the month of November, Washington on Wheels Mobile Health Clinic continued to serve the members at the Fremont Senior Center, the Fremont Family Center, Resource Center, the Silliman Activity Center in Newark, the Ruggieri Senior Center in Union City, and the NUMMI Reemployment Center. WOW provided healthcare services to students and family members at Irvington High School, Kennedy High School, Robertson High School, and Breyer Elementary School, all located in Fremont. They provided influenza vaccines to several companies located in Fremont, including Lee's Imperial Welding, Thermo Fisher, which is a provider of analytical instruments, laboratory equipment, and supplies, West Coast Quartz, a fabricator specializing in the semiconductor industry, and Scientech, a supplier of chemicals used in manufacturing. They also provided pulmonary function testing for Matheson Trigas. They're a provider of a variety of specialty gases located in Newark. In terms of internet activity for the month of November, the hospital's website had 28,563 visitors, 19,849 unique visitors, which resulted in 86,917 page views. The links most visited included the employment section with 16,630 page views, the physician finders section with 13,638 page views, the volunteers section with 7,607 page views, About Washington Hospital section had 7,301 page views, and the Women's Health and Pregnancy section had 3,165 page views. During the month of November, the InHealth staff completed a variety of new productions, including a new programs about the first step that goes into the commissioning of the new central plant. Staff also completed a health and wellness program Dr. Barbara Kostick presented about vitamins and supplements. That's been in the news quite a bit in the last few months. InHealth also covered the Diabetes Health Fair and captured a Diabetes Matters lecture focusing on food shopping strategies for people with diabetes. All of these projects were in addition to capturing the recent Trees of Angel lighting ceremony and producing the Central Plant open house video that aired during the Central Plant grand opening. WHEA's department wish list allows departments to pick specific items to purchase that are directly related to patient care in their respective areas. The deadline to submit a request was November 11th. The recipients of the department wish list funds will be announced at the regular WHA meeting on December 14th. I guess that was today. I don't know what they announced. WHEA's Seeds Candy Sale concluded on the 11th. our members purchased pound gift certificates at a saving of $2.50, and the certificates were sold, profiting WHEA by nearly $500. The Tri-City Volunteers Food Drive concluded on Friday, November 18th. They collected 32-gallon bins of dry food for Tri-City volunteers. It's a job well done. For their membership, they sold discounted tickets for the Oakland Raiders Denver Broncos football game and the San Francisco 49ers St. Louis Rams game. And both of the football events were sold out. Their annual children's holiday party took place on December 9th. Admission to the event was $3 per adult and $2 per child. The event included a performance of Rudolph the Ugly Duckling, and other cracked-up holiday stories. They had treats, gift bags, and a picture with Santa. The event was a sellout. The Employee of the Month for December is Anna Walker. And I have to say that she is really someone special here at Washington Hospital. She joined our hospital 31 years ago as an LVN in 1980 and was promoted to LVN 3 in 2001. She worked in the medical and surgical departments throughout her tenure until 2008, when she joined the Simulation Center. Anne has played an important role in the education of Washington Hospital staff, physicians, and Cal State University East Bay nursing students, promoting patient safety and the patient-first ethic via the use of human patient simulators. Anna was instrumental in helping Washington Hospital obtain magnet status. She assisted with the education of the interdisciplinary team members and played an active role during the site visit. She's been a valuable asset to the Patient Care Services Division and the Simulation Center since she started her career at Washington Hospital. I couldn't think of somebody better to recognize. That finishes my report.
Thank you. So now we're going to move on to the quality report. Stephanie?
Thank you, Mike. Tonight I'm going to be presenting the quarter ending 2011 of the Quality and Patient Safety Dashboard. Procedure timeout is one of our patient safety goals, and that's a checklist to make sure it's the right patient, it's the right procedure, it's the right site. These are some of the things you would find in a procedure timeout. And we met goal at 99.9% for the quarter. And this is more a documentation issue. It's done routinely, but it has to be documented in the medical record for the credit to be given. Looking at our falls with moderate injuries, we are below the benchmark, which means we are better than the benchmark in terms of falls with moderate injury. We continue to look at strategies to prevent falls. One of the strategies we are looking at right now is the correlation between certain medications and falls. We are also making sure that the nurses' aides are making rounds for the 4 Ps, which is pain, party, positioning, and placement. We have an active falls task force that continue to look at strategies and cutting-edge technologies out there in an effort to reduce falls. Severe sepsis mortality, as we know, we continue to aggressively pursue reduction of sepsis mortality, early identification and early intervention, increases the patient outcome, better patient outcome, decreased mortality, and we have met goal. There's a lot of stuff that the group with Dr. Aquilili and Dr. Halimi are continue to work on aggressively in terms of sepsis and the community needs. Pressure ulcer, we met goal again, and this is CalNAC. It's in terms of our comparison database, and we met goals. We continue to look at pressure ulcers because now there is some correlation between pressure ulcers and nutrition. So in the future, you'll be hearing a lot more about that, but we continue to see how we can better serve that population, and we continue to look at early detection through identification of high-risk patients. Nosocomial MRSA infection rate, that's any patient that gets an infection, an MRSA infection after 48 hours. There's laws that mandate what population we test for MRSA, and those population we do on admission, but the rest of the population are not tested. So even though MRSA is very prevalent in the community, if they come in and within 48 hours, after being in the hospital for 48 hours, they develop an infection, it's hospital owned. And we had one bloodstream infection for MRSA in the quarter, looking at over 15,000 patient days, and there was just one. So we continue to strive for zero. MRSA is surgical site infection, and this is part of the whole skip in terms of preventing surgical site infection. And we have not had a surgical site infection related to MRSA, whether a bloodstream infection, in the last 2 years. And that is very good in terms of telling us that what we're doing is currently working. And this is we look at all surgical procedures. So we look at your total hips, you look at the abdominal surgeries, you look at the cardiac surgery, your neurosurgeries. Catheter-related urinary tract infection, this has now become a patient safety goal. So, and the CDC has also changed their goal or their benchmark in terms of defining the definition of what is considered a catheter-associated urinary tract infection. We are looking at strategies for the at-risk population. There's a certain population that certainly is at risk for UTI. So there are strategies coming out of the Infection Control Committee that's beginning to look to see how we can better serve those patients, because if we don't, they end up with infections. Ventilator-associated pneumonia, also known as VAP. We have gone over 2 years without any VAP. We continue our strategies, and always out there looking to see what else is out there in terms of technology or in terms of better practice as it relates to VAP. But we are very proud of our data in terms of going over 2 years without any VAP. The nosocomial C. difficile infection rate, and as you know, C. difficile is a gastrointestinal bacteria that can cause diarrhea. Oftentimes it's associated with usage of antibiotics. We continue to look to see different strategies, but the literature is now showing that it's more prevalent in the community than we previously thought. There are different strains of C. difficile. So oftentimes the community is not aware, the members in the community are not aware that they have it. So there's some education that's being planned by the Antimicrobial Stewardship under the direction of Dr. Martin, and you'll be hearing more about that in the coming months. Looking at our core measure data, again, this is for quarter ending September of 2011. And then we show you what's currently on the Hospital Compare website. And this data has last been refreshed as of October 31st, 2011. So looking at our data for quarter ending September, we were 100% compliance as it relates to the prevention of heart attacks and the right treatment. But again, when you look at our data compared to both the state and the national average, we are better than both. Moving on to heart failure. For quarter ending September, our scores speak for itself in terms of getting to that 100% mark. And again, we were better than both the state and the national average as compared to what's out there. Pneumonia. Looking at that for quarter ending September, I want to point out pneumococcal vaccine. That's one of the key indicators as it relates to the pneumonia core measure and good patient care, and we were 100%. And also the timing of antibiotics. Again, our data continues to look good when we compare ourselves to both the state and the national average. The Surgical Care Improvement Project, you heard a little bit about it as it relates to the MRSA in surgical procedures. And again, antibiotic within 1 hour, it was 100%, and that is critical in terms of antibiotic preventions as well as the antibiotic selections. So we were at 98.7%. Another indicator I want to highlight is the venous thromboembolism, and that is the prevention of blood clots. And you see we were 100%. And again, when you look at our data, as it compared to both the state and the national average, we're doing well. Last but not least is the hospital outpatient surgery, and this is the antibiotic timing and antibiotic selection for certain procedures that's done in the outpatient arena, such as your pacemakers, etc. And again, we were 100% in terms of our antibiotic timing and selection. And when you look at our data compared to both the state and national average, we were better than the benchmark. And that's it for quarter ending September. Any questions?
I'd like to make a comment. Stephanie, you presented quite a number of metrics there. And I think the common theme among all of those metrics is that when looking at our hospital from a quality standpoint, we have met or exceeded the benchmark on so many of these metrics. The one thing you can't really show, which I wish we really could, would be to show how this has affected the lives of the patients within our hospital walls. How many lives we've saved, how many infections we've avoided, how many complications which were not seen because of the hard work that has been done in the hospital to create these kind of numbers. I think this is very, very impressive, and I think it really reflects on the leadership provided by Ms. Farber and by the whole quality staff, the nursing staff, the commitment quality throughout the house, which has really, I think, been quite stellar. So I just wanted to reinforce how important that is, that these are not just numbers. This really translates to lives.
I appreciate your really generous remarks about the leadership, but we have leadership in areas of the hospital where it isn't readily seen. And it comes from the medical staff. Doctors like Kranti Achanta, working in pharmacy and therapeutics, Prasad Kilaru, and his commitment to pursuing quality. Jenny Ahn has been very active, and of course the department chairs and the medical staff executive committee as a whole. You know, when we all started wrestling with these issues years back, 4 or 5 years ago now, there wasn't a lot of cooperation, and everybody was trying to point fingers at each other, trying to decide who they could blame. And instead of going down that road, we were able to get everybody focused on the patient first ethic. And now what you see are doctors and hospital staff working together collaboratively. We couldn't get here without the doctors. We have great staff to support them in these efforts, but there are really some heroes in the medical staff that we should be thanking too.
Thank you for those comments.
Thank you. Thank you, Stephanie. Okay, we're going to go on to the finance report with Chris Henry. Hi, Chris.
Okay, tonight we'll be reviewing the operating and financial results for Washington Hospital for October 2011. And we'll start right in with acute inpatient statistics. Average daily census for October came in pretty close to budget at 181.9. We had 1,079 admissions. That's 22 above the budget of 1,057. Patient days were pretty close to budget at 5,638 for the month. Our average length of stay, of course, that's based on discharges, came in just under budget at 5.23. We'd expected 5.34 for October. Moving into utilization, our case mix index, which is our indication of the severity of the cases that we'd seen in the hospital for the month, came in below budget at 1.318, and I think you'll see that played out as we get through these statistics. Deliveries for October were 10 above the budget at 169. While our surgical cases were 47 below budget at 361. That includes our joint replacement cases, which came in 2 below budget at 107. Neurosurgical cases were 15 for the month. We'd expected 21, and our cardiac surgical cases came in at 8. We'd expected 18. PTCA procedures for the month were 20 below budget at 49. We'd expected 69 in October. Outpatient visits for the month were also below budget. We saw 8,739 outpatient visits. We'd expected 9,520 in October. And the emergency room saw 4,173 visits, about 232 below the budget of 4,405. Looking at productivity, we had our productive full-time equivalents for the month landed at 1,454. We had 183 non-productive FTEs, giving us total FTEs for the month pretty close to budget at 1,592.1. That's just 4 above the budget. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in pretty much right on budget at 6.72. We had expected 6.73 for the month. Moving into the financials, total patient revenue for the month came in almost $3.7 million below the budget at $276,000. Our contractual write-offs for the month were slightly above the budget at 74.61%. So we ended October with net operating revenue almost $1.5 million below budget at $40,984,000. Our operating expenses for the month were pretty close to budget, just slightly below at $40,147,000. Largely driven by some offsetting stuff going on in there, but the big movers in our expenses were our benefit expense, as we continue to see a little bit higher than expected health and welfare claims during the year, and our supplies, that was offset by supplies that came in below budget for the month. So we end October with an operating bottom line $1,361,000 below budget at $837,000. Non-operating income for the month came in $165,000 below budget at $1,093,000. And so we end the month with a total bottom line a little over $1.5 million below the budget at $1,930,000. Take a quick look at our Financial Accounting Standards Board presentation. This is the way the financial markets look at us. Operating bottom line stays the same at $837,000. We pull out our tax revenue that supports our general obligation bonds and our unrealized loss on investments of $404,000 to come up with non-operating income from a FASB perspective of $788,000, about $187,000 above the budget, and a total bottom line from a FASB perspective of $1,625,000, about $1.174 million below budget. So, there any questions on October results? Okay.
Ready for the monthly report on November? Okay. The month of November saw 1,001 patient admissions. They resulted in 5,141 days of care. The average daily census in November was 171. This was lower compared to October's average daily census of 182. The high and low ranged from 198 down to 141. The budget for November anticipated 1,008 admissions and 5,394 days of care and an average daily census of 180. So we're going to come in approximately 253 patient days of care below budget for the month. The average length of stay for adults and children in November was lower than budgeted. It came in at 4.86. The budget had anticipated an average length of stay of 5.35. In terms of patient mix, preliminary information indicates that the inpatient revenue for the month of November amounted to approximately $114,010,000 compared to the budget estimate of $120,720,000. Of this amount, 49.3% was Medicare and 10.1% was Medi-Cal, for a total of 59.4% of government program revenue. The birthing center saw 153 deliveries in November compared to a budget of 152. Our deliveries resulted in 336 baby days of care. The newborns totaled 157 in the month, so we had some twins in there. For comparison, there were 152 deliveries in the hospital a year ago in the month of November. In terms of surgeries, we had 329 surgical cases at the hospital versus a budget of 374. This includes cardiac surgical cases that were 9 below budget. They numbered 7. Inpatient surgical activity was below budget by 48 cases, while outpatient surgeries were above budget by 3. At the outpatient surgery center, we saw 558 cases, more than called for in the budget of 542. For the month of November, there were 350 cases seen in the cath lab, including 44 PTCAs. Total cath lab cases were lower than budget by 66 cases, or a 15.9% negative variance. And PTCAs were lower than budget by 20, or a 31.3% negative variance. Cath lab procedures were 36 fewer than anticipated in the budget, while outpatient procedures were 30 lower than expected. In terms of non-emergency outpatient visits for the month of November, we had 8,579. This came in below the budget of 8,922. The emergency room recorded a total of 3,945 patients, a daily average of 132, 209 below budget. The Washington Clinic, Warm Springs Clinic, Newark Clinic, Nakamura, and Ohlone and Walmart clinics saw approximately 3,775 patients during November. The total system emergency room and clinic visits for November are 7,720 compared to a budget of 9,067 visits. Full-time equivalents for the month of November totaled 1,587.8, including 30 agency personnel. This was higher than the budget of 1,563.7 FTEs. FTEs per adjusted occupied bed came in at 7.15, above the budget of 6.76. Productive FTEs came in below budget for the month. November had, in summary, 7 fewer admissions and 253 fewer patient days than anticipated in the budget. Our surgical caseload came in below budget by 12%, and the cath lab procedures were below budget by 15.9%. Outpatient visits for November were below budget by 3.8%, while the ER visits were 5% lower than anticipated. Clinic visits for the month were below budget by 23.2%. Total paid FTEs are above budget by 1.5% for the month and below the last 12 months average by 10.9 FTEs. Inpatient charges for the month were lower than budget by approximately 5.6%. Outpatient charges appear to be lower than the budget by 2%. So our total hospital charges, healthcare system charges for November are projected to come in below budget by 4.8%. On November 30th, there were 163 days cash on hand. The total days revenue and accounts receivable at November 30th was 74.11. The days revenue and accounts receivable excluding Medi-Cal was at 61.56. During the month of November, $2,633,000 of charges were approved or pending for charity assistance.
Questions? All right, thank you, Nancy. We are now going to move into the portion of the meeting that's dedicated to action items. And before we do that, I think that we are going to, the first thing that we're going to consider is the the Chief Executive Officer's employment agreement. And I think that it's appropriate at this time to have Patricia Danielson, who was the president of the board during the last calendar year, make her comments regarding the performance of our CEO, Nancy Farber. So, Patricia, would you like to please proceed?
Thank you. Thank you, Mr. Wallace. Tonight, we will be discussing the CEO's agreement. Specifically, we will be considering possible adjustments to the CEO's cash compensation and extension of her employment agreement. As the board member leading the discussion, I want to take a few minutes to provide my perspective on the board's process for review of the CEO's compensation. During our previous meeting, October 9th, we heard from our healthcare executive compensation consultant, Integrated Healthcare Strategies. Mr. Eric Reel of Integrated Healthcare Strategies presented his annual report for the board's consideration. As Dr. Stewart pointed out at the last meeting, there always seems to be some confusion regarding the reasons why we ask Integrative Healthcare Strategies to provide us with an annual report. I want to take a moment to review what Dr. Stewart said, which I think is important for our discussion tonight and for the public's understanding of our process. The Board of Directors has general oversight over the running of the district. That oversight responsibility includes the evaluation of the performance of the CEO and includes making adjustments to her compensation consistent with our compensation philosophy and Internal Revenue Service guidelines for establishing reasonable compensation. In order for us to properly fulfill our duties in that regard, annually we obtain compensation data from an independent and qualified healthcare executive compensation consultant. As we know from past presentations, Integrated Healthcare Strategies is the leading healthcare compensation consultant in the United States. Hundreds of healthcare systems use Integrative Healthcare Strategies services on an annual basis to assist those organizations with the very same process we follow here at Washington Township Hospital District. The report from our consultant tells the board that the current range for compensation for CEOs of similar healthcare systems. Integrated uses its own proprietary database and, in addition, uses 2 other commercially available databases in its analysis. The bottom line is, the report provides us with information we need in order to make sure that we are paying the CEO fairly and appropriately. I also want to take a few minutes to make some preliminary comments about the district, which are important for understanding the challenges and complexities in running our district. First, I want to remind everyone of the key differences between the Washington Township Healthcare District and other forms of government agencies like cities and counties. The biggest difference is that the district does not receive any taxpayer dollars to cover its operations. We are a self-sustaining organization. That means that our revenue comes from sources other than taxpayer funds. The principal source of our revenue comes from patient-generated revenues. We get paid from insurance companies like Blue Cross and Blue Shield, as well as from governmental programs like Medicare and Medicaid. The general obligation bond money that was approved through Measure FF in 2004 goes only towards specific new construction projects. That money is kept in separate accounts and is monitored by a Citizens Bond Oversight Committee. Another key difference is that we must compete in a very challenging environment with other healthcare providers for both staff and patients. We must compete for our employees and executive leadership from the same labor pool as other comparable for-profit and not-for-profit healthcare providers, not with local cities or counties. As a result, to recruit and retain top-quality professional staff, the hospital must pay market rate salaries based on comparable health care facilities. It is our ability to attract and retain top-quality professional staff that has allowed our district to provide the best care to our residents. In addition, the district is not just the hospital, but is a multifaceted health care system. Our community, including those of us who serve on this board and who work here, often refer to the district as Washington Hospital or the hospital. It is easy to understand why. The district was conceived with the goal of building a hospital. However, today the district is much more than just a hospital. The Washington Hospital Healthcare System includes the Institute for Minimally Invasive and Robotic Surgery, the Gamma Knife Center, Taylor McAdam Bell Neuroscience Institute, Joint Commission Certified Stroke Program, American Diabetes Association ADA Certified Diabetes Program, the Cardiovascular Institute, the Washington Women's Center Cancer Genetics Program, the Outpatient Imaging Center, Washington Radiation Oncology Center, Washington Outpatient Surgery Center, Washington Outpatient Rehabilitation Center, Washington Center for Joint Replacement, Washington Urgent Care, Washington Clinic Newark, Washington Clinic Warm Springs, Nakamura Clinic, Union City, Washington Township Medical Foundation, Ohlone Student Health Center, Washington Properties, a 4-acre retail center, medical office building at 1900 Maury and 2500 Maury Avenue, Washington on Wheels, Washington Clinic for Wound Healing and Hyperbaric Medicine. Lastly, there is one more related point I want to make, which is, it has always been the mission of this board and predecessor board that the district's assets, including Washington Hospital, remain under control. In order to keep local control, our district must remain financially strong, while at the same time provide for the needs of its residents. Unlike certain other healthcare districts in California, we do not ask our residents to fund our operations, and we intend to do whatever we can to keep it that way. As a board, we could not do this without the leadership of our CEO. Here are just some of her major accomplishments this year. Washington had a strong financial performance in fiscal year 2010-11 compared to other hospitals. The total net operating income for our last fiscal year was $36.8 million, well above the budget. Last Thursday, the board cut the ribbon on our newly completed central utility plant, a very complex construction project and a critical piece of infrastructure needed to support the operations of the hospital in the decades to come. The central utility plant was completed on time and on budget, almost unheard of for a public works project. Again, we were able to provide millions of dollars for charity care. Specifically, in 2011, Washington provided $44 million in healthcare services to the district's medically indigent who could not pay. I want to repeat that, $44 million. This includes care provided for free and also care provided to the Medi-Cal population that Washington subsidizes, since the hospital is compensated much less than the cost of providing care. Just as we did last year, I would like to break the discussion down into 3 separate discussions. First, I propose that we discuss the award of at-risk performance compensation, followed by a discussion of a possible adjustment to the CEO's base salary. Third, I propose that we discuss the contract extension. I'd like to ask if other board members at this time have any other comments to add.
Anyone? Nope, nothing. That was well said, Pat.
Thank you. It's quite a speech.
Yes, indeed it is.
And I think we missed a few points, a few accomplishments on there, but I think everybody gets the gist of it. We've got quite a, it is quite an extensive system that we have developed here, far from what the hospital originally started out as.
Yes, and I think I'd just like to add, as you were going through that, that this is not, sometimes organizations will have sporadic performance, and what I would want to say is that the performance has been consistently good, and it wasn't like last year was all that abnormal compared to the previous year, a couple of years. It's been stellar over the last recent 5 to 10 years, and certainly during Ms. Farber's tenure as a CEO has been exemplary. So it's not something unusual that is
No.
that really occurred last year.
No, if you think of it as a graph, we're not doing one of these numbers of up, down, but it's a steady incline,
Right.
and it's very, very consistent. Jacob, did you have anything to add? No? Okay. Gentlemen?
Well, I think I've made my comments with respect to how quality works within this hospital, and I think that just represents one facet of consistent performance, and that I think is a theme here tonight, is consistent performance, outstanding performance, and that performance really does have a purpose, and that purpose is to be able to provide for health care to our community. And that's really what we're here all about. Our hospital's doors are open to everyone. We can't say that about other healthcare institutions in our community, but our doors are open to everyone. And one of the ways in which we do that is by having good, solid financial performance, and that financial performance is based upon top quality performance in all of the operational aspects. And so I think that reflects well upon Ms. Farber and her management team, and I think it's outstanding.
Yes, and I think a lot of folks in the community may get the wrong impression about charity care or uncompensated care. The reality of the world that we live in this country is that if someone shows up sick at our doorsteps, there is no legal way, and certainly there's not a moral or ethical way, but there is no legal way that the hospital can turn that person away, whether they have a dime in their pocket or no dime or whatever amount of money they have. And so much of the costs that we incur, I'm not saying that we wouldn't incur them anyway because of the high ethical standards we have in our community and the role we play in supporting our standard of living in our community. But the reality is it would be illegal for us to not treat those patients. And consequently, we incur costs that are unreimbursed. And we might call them charity, we might call them unreimbursed. The reality is we didn't get paid $44 million in charges last year, and we still managed to make $36 million in net income after that.
Mr. President, I'd like to also add my comments to this. I think it's really important for the community and the district to understand that all the salaries in the hospital are paid through operations, that none of them are paid through any bond measure or any property tax levies or anything like that. The hospital is self-sustaining in terms of operations. And we're able to do that in addition to providing all of the various programs that Pat has indicated, plus, as she has said, even more things than were even listed there. I enjoy myself going to many of the education systems, programs that the hospital has. The charity care is certainly a large portion of that, and I think we can be very, very happy with the operations of the hospital. Very, very pleased with the direction that Nancy Farber is able to give those operations. We're very, very fortunate to have her in that position at the hospital. I'm anxious to support her in that role, anxious to see that she's properly compensated. Thank you.
Thank you.
Going on. As I had itemized, the first item we should be discussing and focusing on is the at-risk performance compensation. That is the first item under consideration. As part of the CEO's annual review, the board also reviews Mrs. Farber's overall performance and strategic achievements. Our compensation philosophy targets total cash compensation at the 75th percentile of the selected peer group. According to the Integrated Healthcare Strategies presentation, we could award up to the maximum award of 40% and still be below the 75th percentile. Over the years, consistent with standard practice in the industry, the board has granted an award of up to 40% of base salary to reward the CEO for her performance. Awards made clear or at the 40% level are made when the CEO does a truly outstanding job. We have also made awards at far less than the maximum when the performance was strong but not outstanding. In my opinion, the CEO's performance this past year justifies the maximum award given the overall performance of the healthcare system and the achievements that have been made, especially when considering the difficult economic climate and the great uncertainty surrounding healthcare reform. This high level of success is evident in our financial statements and the numerous accomplishments, including achieving magnet status. The following are but a few of the accomplishments. To begin with, as I indicated already, Washington Hospital fiscally outperformed many hospitals in California and nationally, earning more than $36.8 million in operating income. Completed and opened the Central Utility Plant, a complex construction project on time and on budget. Kicked off the planning and implementation for the EPIC, the Electronic Medical Record System, which is a vastly complex task involving all aspects of the healthcare system. Implemented Washington Township Medical Foundation. Opened the Washington Center for Wound Healing and Hyperbaric Medicine. Continued construction on the new Center for Joint Replacement. To date, the project is on budget. Implemented the concierge program at Washington Hospital to serve patients and their families. Implemented the endoscopic ultrasound program. Completed and held a ribbon cutting and open house for the Sandy Amos RN Infusion Center. Continue to increase our community education and screenings for the community and our programming on InHealth. We also had a clean audit with no findings or adjustment. And as Mike just said, this is not a brand new happening. This is consistent with our performance of the hospital. As stated, provided more than $44 million in health care to the community's medically indigent population, in addition to providing $3 million for community education and other expenses and $82 million in uncompensated cost of care for Medicare patients and bad debt. Significant awards and recognitions that we have received in this last year are as follows. Washington Hospital has been granted magnet status recognition by the American Nurses Credentialing Center. A magnet designation is the highest of recognition that a hospital can achieve for nursing excellence. Only 6.7% of hospitals in the entire United States have earned this status, and Washington Hospital is one of 4 hospitals in the Bay Area to have this designation. The Center for Joint Replacement received the 5-Star Customer Service Award and the Top Performer Award from Professional Research research consultants. The CJR scored in the top 10% nationally based on excellent patient responses. Healthgrades named Washington Hospital Center for Joint Replacement the #1 joint replacement program in California. Healthgrades is the leading nationwide healthcare ratings information and advisory services company. Washington Hospital Stroke Program received the 2011 Healthgrades 5-Star Award for ranking among the top 15% in the nation for treatment of stroke. Washington Hospital received the 2011 Healthgrades Award for Patient Safety Excellence, which places the hospital among the top 5% in the nation for patient safety. Washington is the only hospital in the East Bay and among one of the only 268 hospitals nationally to receive this distinction. August 2011, Washington Hospital, for the third time in a row, was awarded the Gold Seal of Approval from the Joint Commission for Primary Stroke Centers. The Joint Commission named Washington Hospital as a top performer on key quality and patient safety measures. It is a prestigious distinction awarded to an elite group of 405 hospitals across the country that follow 22 important best practices 95% of the time or better. As we all know, these accomplishments have occurred in a very challenging economic time and are directed and a direct reflection of the success of the institution and its leadership. The CEO has earned her award. She and her executive team have increased services and improved the quality of care, while at the same time investing in the future of the district with a central utility plant and the IT structure through the implementation of the EPIC electronic health record system. With all of this in mind, I would like to open this item up to the public and board comment. The options available to this board as I see them are: do not award any at-risk incentive compensation. Make an award based on the CEO's performance this year within the range of 0 to 40% of base salary. And if you recall, Integrated Healthcare Strategies presentation on page 25 of their report, the ranges were: a 10% award would equate to $63,217. A 20% award would equate to $126,434. A 30% award would equate to $189,650. And finally, a 40% award would equate to $252,867. I believe that based on the overall performance of the district alone, we could justify an award at the highest amount, consistent with our compensation philosophy, so I'm recommending that we award 40%. If there's any member of the public that would like to address this, please do so now. Otherwise, I will open it up for board comments and other proposals. Seeing no comments from the public, I open it up for the board.
Gentlemen?
As I've stated before, I think it's very, very important for us to properly compensate our CEO. The Integrated Health Strategies report clearly stated that we could award a 40% at-risk performance compensation and still be below our board policy of providing compensation at the 75th percentile. Based on last year's performance, it's absolutely impossible to deny the fact that the hospital had a spectacular year in every area of our operations. Pat has mentioned all those, and we don't need to belabor those, but it's a spectacular performance. So I, for one, would be very much in favor of awarding a 40% at-risk performance compensation.
Jacob, any comments?
Well, I mean, I think pretty much all the merits have been pretty much narrated. But what I really want to emphasize again is, which we do pretty much every year, that we had kept certain targets, and the leadership was able to fully achieve that. And and these were the goals that were set by us. And once it is achieved, I don't think we have anything to go back on that. So I think it is pretty as transparent as possible. And I'm just hoping that the people in this community who have elected all of us would really appreciate a well-run hospital that's able to deliver quality service at the same time, give as much free service to the indigent population, which is actually increasing in this community. So, I don't have any reservations at all, and I would probably approve the 40%.
Bill?
I would agree with that, and I would like to reinforce that what we're looking at right now is the at-risk performance compensation. The performance refers to the performance of our CEO, and that has generated the quite stellar performance of our institution. So I would concur with a 40% at-risk performance compensation award. And with the permission of the board and the president, I'd like to make a motion if you're ready for that.
I just have one more thing I'd like to say.
Certainly.
And it's it's really, you mentioned at risk, and I think that's the important thing for members of our community, and all of us to remember. There are many things that go on in the healthcare industry. Much of what goes on is certainly not predictable and not controllable, and is somewhat random from time to time. And coming to a position where you understand all of that is possible, and payers are continuing to restrict payment. I look at the financial report every month here, and I just remember back in 1990 when I came on the board. At that time, the hospital was collecting around 68 cents on the dollar. 32 cents on the dollar was just not collectible because of different contracts with Blue Shield and all the big providers, or Medicare, or the federal government, or the state. But we still managed at that time to collect 68 cents on the dollar. If you were looking at that report this morning, or not this morning, a few minutes ago, we were not collecting 68 cents on the dollar. We were collecting something around less than 25 cents on the dollar from the charges, and the charges are comparable charges to other hospitals in our area. It is remarkable that we can attract and retain the talent of someone like Ms. Farber, who's willing to take this much of a percentage of her compensation as at-risk compensation, given the strange times and world that we live in the healthcare industry. So, yes, Bill, I just wanted to say that, and then I'd entertain your motion.
Yeah, I agree that we live in difficult times, and I think we have even more challenging times ahead. As such, I'd like to make a motion. In accordance with district law, policies and procedures, I moved that based on the outstanding performance of the CEO, as discussed here tonight, the board award Nancy Farber, CEO, the maximum at-risk performance compensation award possible of 40% of base salary, which equals $252,867 to be paid forthwith.
Second.
May I have a second? Any comments or questions? Okay, all those in favor? Aye.
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 Opposed? Motion passes.
Thank you.
Patricia?
I would now like to turn to the discussion of a possible adjustment to the base salary. Washington Hospital has a process in place for determining compensation for all employees, guided by a long-standing compensation philosophy of parity. What this means is that compensation is based on market parity. This philosophy is in place to ensure that we offer competitive compensation and are able to retain and attract the type of high-quality leadership that has made our community hospital one of the top institutions of its kind. Consistent with this philosophy for wage parity, the board adopted a compensation philosophy with regard to the chief executive officer, which positions her base salary in a range around the 65th percentile of the selected peer group. Yet, in the case of the CEO's base salary, we have been unable to maintain her base salary at the 65th percentile for various reasons, including the fact that in 2008, our CEO voluntarily rejected a salary increase of 4% and in the past has agreed to accept less than the amount recommended by the integrated healthcare strategies to reach the 65th percentile. This year, the gap between her base salary and the 65th percentile is even greater than in the past. I think it's around 16%. We as the board know we cannot just make up the difference in 1 year, and I know that our CEO shares that view, as she has voluntarily rejected a salary increase in the past and has previously agreed to accept less than the amount that would bring her to the 65th percentile, in recognition that we are a district healthcare system. We as the board appreciate her willingness to work with us on this. With that said, I would like to open this discussion up for the public and the board comment. The options available to this board, as I see them, are do nothing, keep the base compensation the same, follow our compensation philosophy and adjust salary upwards to meet the midpoint of the 65th percentile based on the report provided by Integrated Healthcare Strategies. Consider a smaller increase, which I propose for discussion purposes to be at the 3% level, which is approximately equal to the average increase for executive compensation as reported by Integrated Healthcare Strategies. And I'll turn it back over to the board.
Comments, anyone?
Mr. President,
Yes, Dr. Stewart.
seems like we belabor this issue, but the bottom line is that as much as we would like and have tried to properly compensate our CEO, Nancy Farber, we have nevertheless fallen behind in that quest. However, I think it's also important to know that while we rely on integrated health strategies, we're certainly not bound to that. We're certainly not doing that out of blind obedience or looking only at that and doing what we're told to do. This board looks at all of the issues very carefully. This board looks at all the possibilities and all of the reasons why and why not, and makes an intelligent decision based on all of those factors. It's a very difficult decision, a very, very time-consuming, very laborious decision to look at those facts and look at all the possibilities ahead in front of us. In all of that discussion, in an ideal world, we might do many things. But I think tonight I would be in agreement with the proposal to offer a 3% salary, to a 3% increase to the base salary of our CEO.
Thank you, Dr. Stewart. Any other comments from board members? Okay, Dr. Nicholson?
Yeah, I would concur with a 3% base salary increase, recognizing that this is one of the few things where Washington Hospital is really rather behind the curve in performance in our compensation strategy. In accordance with district law, policies, and procedures, I move that the employment agreement between Washington Township Healthcare District and Nancy Farber, CEO, be amended to increase the base salary by 3%, effective November 1, 2011, and further that the President of the Board is hereby authorized to execute an appropriate form of amendment to reflect the increase in base salary as provided for in this motion.
Okay, thank you. Do we have a second?
Second.
Okay, any questions or comments? All right, all those in favor? Aye.
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 Opposed? Motion passes. Thank you. Patricia?
The last item, and the third item under consideration, is the adjustment to the CEO's contract. Typically, the Board of Directors annually considers an extension to the CEO's contract by 1 year. I think you know my view is that we are getting excellent value and therefore propose that we extend the CEO's contract by another year.
Okay.
Mr. President, I would have one comment on that. At least at this point, we have an easy issue to vote on.
What's that?
I said,
I didn't hear you.
at least at this point, we have a very easy decision ahead of us.
Oh, yeah.
Very much in favor of voting for this.
Dr. Nicholson?
Yeah, I think this just reflects the confidence that we have in Ms. Farber, and as such, I will put forth a motion. In accordance with district law, policies, and procedures, I move that the employment agreement between Washington Township Healthcare District and Nancy Farber, CEO, be extended by 1 year for a new term beginning November 1st, 2011, and ending October 31st, 2015, and further that the President of the Board is hereby authorized to execute the appropriate form of amendment to extend the term.
Thank you.
Second.
Thank you. Any questions or comments? All right, all those in favor?
Aye.
Aye.
Opposed? Motion passes. Okay, thank you. Director Nicholson, we have
More motions?
More work to do.
More work, okay. So, item B. Mr. President, in accordance with district law policies and procedures, I move the Chief Executive Officer be authorized to proceed with the implementation of the Service Desk Tool Project for a total capital amount not to exceed $427,376. This equipment was included in the fiscal year 2012 fixed asset capital budget.
Second.
Thank you. Any questions, comments? Nancy?
First, I'd like to go back to the previous issue and thank the board for their consideration, for giving me the full amount of my at-risk compensation, for the extension of my contract, and for the consideration of a modest increase. I'm deeply appreciative. Thank you. The Service Desk Tool Project replaces a manual paper system that's cumbersome, problem-prone, and difficult to research. With the EPIC system being installed and the expansion into physician offices, we expect a significant increase in trouble calls, and we need an integrated system that can handle service request tracking and escalation effectively. So we're making this request. It'll take approximately 6 months to complete, and we would ask the board to approve this.
Thank you. Any other questions from the board?
Just a clarification, Nancy, this is going to be completed well before our implementation, full implementation.
6
of that.
months it will take.
6 months, we'll be done
Yeah.
with this. Good.
It'll appear on the calendar that we keep
Mhm.
for the EPIC tracking. We're going to add it there.
Good, okay.
Thank you. Any other comments or questions? All those in favor?
Aye.
Opposed? Motion passes. Item C.
Item C, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to purchase 2 Stryker System 4 power saw and drill systems for an amount not to exceed $54,189. This equipment was included in the fiscal year 2012 fixed asset capital budget.
Thank you. Do we have a second?
Six.
6.
Six.
I'm sorry.
We have a second? Julie? Didn't hear a second.
I'm sorry, second. We were discussing 4 or 5.
Oh, okay.
I'm sorry.
Okay. So we have a second. Nancy, would you like to give us some
Yeah,
color?
we currently own 7 Stryker System 6 power saw and drill sets. And this is equipment that's very heavily utilized in upwards of 1,780 procedures a year. We have to sterilize the drills after every use, and over time, preventive maintenance is required. Adding 2 new sets to the rotation would lessen the need for constant sterilization, which in turn would lengthen the useful life of the equipment. This is something that was in the budget, fixed asset for this year, and we'd like to go ahead and get them.
Thank you. Okay, any other questions or comments? No. Okay, all those in favor?
Aye.
Aye.
Opposed? Motion passes. Director Nicholson?
Item D, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to purchase barcode verification equipment for an amount not to exceed $375,251. This equipment was not included in the fiscal year 2012 fixed asset capital budget.
Second.
Second. Okay, comments, Nancy?
This is technology that complements our EPIC electronic medical record implementation. It also enhances patient safety in the administration of patient wristbands and documentation of accuracy in the lab in terms of specimen tracking and blood administration, in the pharmacy in terms of medication inventory and dispensing, and at the bedside, medication administration. We began the introduction of barcode technology to the medication process with the implementation of the Med Carousel technology earlier this year. This purchase would further integrate the barcoding technology throughout the house.
Thank you. Any more comments or questions?
No, I think this is a critical path in the progress towards safety, especially with respect to medication administration, is having that barcode verification happen at the bedside. So yeah, I think it's a very good investment considering our IT infrastructure, which is moving in place.
Thank you. All those in favor?
Aye.
Opposed? Motion passes. As you were making these motions, I was thinking, month in, month out, ultimately, we end up spending a lot of money, which is pretty much aligned with the budget. And in terms of even thinking about your compensation review tonight, I think the community should know that our budget is around $500 million a year, which is a substantial amount of money that you and your staff, and of course, we as trustees are responsible for properly managing. And it's not a small sum, and I'm proud of the way that all of us come together and manage that for the good of our residents.
Yes.
Okay, Bill?
Item E, Mr. President, I'm pleased to present this motion. In accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to execute a memorandum of understanding and any additional agreements necessary to implement the service arrangement with Operation Access to provide low-risk, ambulatory, elective surgery, and specialty procedures to people who reside in the healthcare district and who need the services but do not have the health insurance to pay for them.
Second.
Second, okay, Nancy?
I'd like to invite Ed Vahan forward to the microphone to talk a little bit briefly to the board about this program.
Thank you, Nancy. So Operation Access is a nonprofit corporation that was started in 1993 with the goal of helping the uninsured gain access to health care. Currently, Operation Access has relationships with over 90 community clinics, 1,000 medical professionals, and 33 medical centers throughout the Bay Area. And it is a service that receives referrals from practices or clinics in the community of patients that need ambulatory or relatively minor procedures, and they don't have the insurance to get it done. And so they screen patients, they provide them with some education, and then they make the referral to us for whatever diagnostic and testing and procedures need to be done. And so this is a contract with that entity to provide these services, which is obviously totally in keeping with the mission and vision of the district.
Thank you. Any questions of Ed? Any other,
I have a
Patricia?
comment. I'm very pleased that the district is able to provide this service, this additional service for the residents of the district. I think it's a very, very good thing that we can do this.
Okay. Yes.
I think it's quite remarkable that despite the fact that you've already provided over $44 million of uncompensated care, that you're willing to step up and do even more.
Okay, thank you. Mr. Romero.
I think the other thing that, and perhaps John could comment on this also, is that the services are going to be provided by physicians without compensation. That's the plan. Mm-hmm. As well as the facilities and material. So it's a coordinated effort by all of us. I think it really reflects the culture of this institution as far as our ability and our willingness and the ability to provide care to all of the district members.
Yes. Okay, we have a second. So all those in favor? Aye. Opposed? Motion passes. Item F.
Item F, Mr. President, I move for the approval of the Medical Staff Department of Surgery Manual, Neurosurgery Section, Privilege Recommendation.
Second.
I know this is going to be a tough one. No, I'm just kidding. Okay, I don't think there's any comments or
Not
questions.
unless the chief of staff wishes to make any.
Would you like to?
Pretty straightforward.
Okay. All right, then, all those in favor?
Aye.
Opposed? Motion passes. Thank you. Are there closed session items?
Yes, there are.
Okay, well, at this point in the evening, we are going to adjourn the open session and convene a closed session. So, we're going to reconvene the open session and announce that no actions were taken during the closed session. And seeing that there is no further business tonight, this meeting is adjourned.